let us tell, okay, debates, and this means debates, and we are welcome all the doctors around the world, except one small exception. We are not welcoming here doctors from Russia. This is not for yours. As I have seen on the platform, there are some. We will be glad if you will leave this session. All the rest are welcome. Widzę, że jest dużo z Polski, też witam wszystkich. And I will give the word to my colleague, to the famous and really very good doctor, Dr. Alberto Leguina. Alberto?
Hi everyone, thank you so much for being here. It's a big pleasure to join you all. I want to just confirm with our team. I can see in the chat that people are saying that there's no audio, there's no sound. Please, our service team, can you tell us, confirm that we are having the voice active?
No, it's okay.
Because I was reading the chat. So, okay, so I really want to thank everybody to be present. It's a big pleasure. My special appreciation for my people, my colleagues from South America, but also from the Middle East for being present at this time. As Dr. Turkevych mentioned, we're going to be discussing different topics regarding dermal fillers, and even when it's called a debate, I think we agree in a lot of those topics. Still, it's going to be very interesting to hear from you and also to have your feedback. So, Dr. Turkevych, yes.
So we need to ask the moderator to put the presentation on screen. You can switch me off right now, just leave Alberto and presentation. And I will manage it. Great. So, Alberto, you are starting?
Yes, I cannot see your PowerPoint. 1 second, can you? I'm not seeing, okay. Okay, so that is regarding Dr. Turkevych. It's a highly appreciated speaker for today. Just one slide before, please. I just want to do a little disclosure regarding my presentation, because my goal is not to attack or offend any of the brands that I'm going to mention. Most of the data that I'm going to show you, it's based on peer review publications. And the idea is that we use scientific evidence and medical evidence to support our concepts. So my first myth is about dermal fillers, if they can lift. My position is against it, and I'm going to tell you why. Please, can I have next one? Oh, here. So, cadaveric studies have shown limited effect or evidence. However, the lift effect we observe in injections is based on the stretching of the skin. So I'm going to tell you a little bit why. Please, can I have the next one? What has been the concept we are seeing in all social media, but also in the marketing industry of aesthetic medicine, about how with fillers we can elevate eyebrows, restore volumes, tighten the skin, lift corners of the mouth, minimize crowd feet. And as you can see in this schematic, at least 2 or 3 times the concept of lift or elevation is used. Can I have the next one, please? And when you Google liquid lifting, that has been this concept for the last 10 or 15 years, you can find all this before and after in which they show the lifting effect of fillers. So the next one, please. However, what is the real evidence regarding this? Everything started, or everything took a lot of strength with the paper of Dr. Sebastian Fotofano. He's a very well-known anatomist. He works in the Mayo Clinic, in which, in cadaveric studies using soft tissue fillers, he saw a level of elevation, specifically or lifting, when the temporal region was injected at supraperiosteum. The classic head shock technique that we use, the 1-1 technique in the temples, that it was showing an improvement on the mid-face and mandibular angle. And very important, the level of evidence of this study is therapeutic level 5. Grade 5, sorry. Then Dr. Inigo de Felipe, Dr. Redondo from Spain, I know them personally. They published in the TCAS symposium a very unique setting, to say it in a very polite way, very unique. So please, so what was the setting of this study? Please, Dr. Turkevych, can you put this one? Okay, next one, okay. So what they did, they injected 8 ml of hyaluronic acid reticulated, but it was diluted with 6 ml of saline, plus 2 ml of anesthesia. Then this mixture, that is already a little bit suspicious to say at least, it was injected from one entry point, posterior frontotemporal area to all the face with cannula, and what they observed, or what he observed, is a level of elevation. And then these are some before and afters that you can see. For example, on one of the things that have been questioned about this paper is that you can see even in one of the figures in the right one, the patient in the nasal area follicle is smiling a little bit, and then the patient is relaxing the face. You can see also some difference in the light that was taken, and the figures are based on only subjective evaluations. Please, can I have the next point? And then he made classic surveys to the patients, and he asked the patients if they liked the result, if they saw a difference, and so on. And he concluded, based on that evidence, that this mixture and this injection of basically around 12 ml of product, that is hyaluronic acid plus saline plus anesthesia, was creating a lift. However, what has been the new evidence? And this is a study by Jan Westborn. This study is also from the United States, in which an objective, quantitative, dynamic assessment of the adaptation of the hyaluronic acid fillers to the face. So what is the position? It's that we don't have a lift, we have real stretch. And for that, I brought a little prop, and this is a little balloon, but this is basically one prop that I use in the clinic, because for me also this concept was a little bit complex. If you inflate the balloon, and I always say to my colleagues when I do the trainings around the world that the skin is basically this rubber. When you inflate the balloon, you get a volume. And this volume will represent the volumes of your face. And there is a little attachment. Think about that as the ligament. If you inflate more the balloon, more than what it was originally, and you compare it, so of course the upper part is going to be higher, but that is not because the ligaments went higher. So we are not changing the area of retention of the bone. We are stretching the skin, volumizing, and we are creating this effect of elevation. And this effect of elevation is dynamic. That's why I brought this little friend to me. Because if we move it, absolutely there's going to be changes of the dynamic. For me, this concept was a little bit hard to understand, and this paper is a very one that I recommend you, all of you, to read. So basically, what these authors and what is one of the new general ideas is that when we overfill or when we create volume, we elevate the tissue through stretching. But if you think about the ligament itself or the area of attachment, we're not creating any real lift. So please, can I have the next one? And the issue is then, we have to understand the level of evidence. I really invite all our colleagues that when we read papers, we are very critical about the type of study. When we have a paper or a study that is a case series, meaning that it's a grade 4 or of evidence versus a grade 5, we're thinking that we're one step forward to a true clinical evidence. So please, can I have the next one? What is the problem? As we try to achieve this idea of elevation through volumization, we are going through the facial overfill syndrome. That is when we want to stretch more and more the skin through volume to create this sensation of elevation when we are not really lifting. Here's the situation, and this is what I told to all my colleagues also around the world. We have to think that the skin is like this rubber. If we go back and forward, inflating and disinflating, also this rubber is going to get damaged. And that's why, step by step, as we are looking to get that result, we're going to also be pushing the limits of the material, that is the skin. The skin, as we get older, is going to be softer. It's going to have some level of elastosis. So we're going to need even more filler to reach that result. So in that conclusion, I just want to say that my position is that dermal fillers cannot leak. They stretch the skin through the restoration of volume, and the concept of limit lifting is a concept that I don't find valid. So thank you so much. Now Dr. Turkevych.
So thank you very much. Well, honestly, I'm totally agreed with Alberto. I'm totally agreed on this topic. Just I have some, I want to share some nuances and my point of view on the same topic. But as I'm totally agreed. Even if you remember, the question was, does the fillers can lift? The right answer is they can't. They can't because it's illogical. If we need to lift something, first what we should do is need to fix. This is from plastic surgery. If we need to lift this, we need to fix here, and after that we can lift. But we can't lift, but let us analyze we should lift or not. What I mean, there is the famous American plastic surgeon, Val Lambros, and he shows the changes, the structural changes that goes with the aging. And if we will analyze what he shows, look, this is the idea of lifting, so-called lifting, yes, after the breast surgery. And on the picture, it looks like the breasts lift up and everything is great. But if we will measure from the fixed point, we saw that there was no lifting at all. No 1 centimeter of lifting. This is just the illusion, the optical illusion. So we can't lift with fillers. We do not need to lift with fillers because of the next, also it's from Val Lambros data. This is the mole, and the difference is 40 years, and there was no ptosis of the mole. Because the idea that the gravity is responsible for the age changes, it's a little bit wrong idea. Gravity is not so responsible. Much more responsible is muscular activity. But what we should do, and what is really important, not to lift, but to achieve the lifting effect. And you have to understand, it's totally different things. Lift, it's to lift up, yes, we can do this, but we can achieve lifting effects in the case that we know what is anatomy, as it is possible. I will show you what I mean as it is possible, because normally we are thinking, especially when we are studying medical university, anatomy is some basics science, and nothing will changes in anatomy, and what new can be shown. Okay, guys, you will see that a lot of new things can be shown. But if we know the anatomy of the face, why I'm talking about this, because I have made we have made a lot of cadaveric courses for doctors, and we have dissected a lot of faces to show the anatomy. There is the line of ligament. It goes somewhere here. And if we know where is the ligaments on the face and where is the line of ligaments, and if we understand the main rule, here you see all the ligaments on the face, yes, and here the line of ligaments is going. If we understand this, If we understand that the deep fat pads, they are more medial from the line of ligaments. And everything what is more laterally from the ligament lines, they are superficial fat pads. If we will know that all the changes, you see they are connected with the ligaments and with that fixation dots of the ligaments to the skin. And if we will understand why it happens with the age, and as I have told, if we will understand that anatomy is not the stable science, it's here are the changes of anatomy and our understanding during last 100 years. And you see that a lot of things were described and were found not so far away, not so long ago from now. And there are a lot of things that we don't know right now. But if we will understand all this, we can find that when we are injecting fillers more laterally from the ligament line, we are achieving so-called lifting effects. Why? Because we have some influence on the position of the ligaments with those injections, injecting under the ligaments and injecting more laterally than ligament line. We are achieving some lifting effect. It's not the lifting. If you will try to measure with the help of centimeter, yeah, we will see that there is no lifting at all, but lifting effect will be. And if we are injecting more medially from the ligament line, we are achieving volumizing effect. So knowing this, we can do some lifting effect with injection on the patient's face, but we should be aware that from the mathematical point of view, there is no lifting. This is just visibility, this is illusion. One hand. Other hand, our patients, they need that illusion. A lot of things that we are doing is just illusion. It changes of lights and shadows. It changes of visibility. These are the changes that goes on the neuropsychological level. So if they're happy, it's great to do this. The only one thing what we should do, it's not to overfill. What was the last slide of Alberto? Is not to overfill. Because if you will inject too much more laterally from the ligament line, it's for nothing, you will overfill, and the lifting effect can be achieved with small quantities, but just into the right places. And to know this, it's necessary to spend some time on cadaveric courses. If you will inject more medially, you will achieve the volumizing effect, and there is no necessity to inject too much. There is also just the necessity to inject in the right places. Well, our second topic, and also Alberto will start right now, dermal fillers have myomodulation capacities.
Okay, thank you so much, Doctor, for very, very informative.
Yes, may I ask to switch on the presentation?
So meanwhile the presentation is appearing, I just want to make a little mention about what is myomodulation, because it's been also something that it's been not only controversial, but it's been a concept not fully understood. So myomodulation is basically to alter the activity of the muscles. One of the classic myomodulators is botulinum toxin, will paralyze muscles. So one of the other concepts that have been through the new era of aesthetic medicine has been about dermal fillers having this capacity as well. I want to do a little disclaimer as well. I do believe that myomodulation exists by dermal fillers. My point of view in this myth is that there is no conclusive data to showing if it's true effect or not. Everything started with the paper of Dr. Del Mayo. Dr. Del Mayo basically took a set of patients, around 15 patients, and he started making before and after photos with or without movements, and then he was injecting dermal fillers, and then he was saying exactly the same movements. It was based on pictures. It was not a quantitative analysis. It was only based on how everything was before and after. However, please, can you put one little point, one extra click, because there is one little part here. Okay, but then, before, please. However, Dr. Kane did a very strong commentary to this paper, in which basically he started discussing certain points of the myomodulation, and this only can reflect of what happened in the industry, but as well as in the different fields of the academic area. So one of the concepts about this paper is that it's very difficult to prove the myomodulation only based on this paper, and this is one of the only papers in the field. He claimed that this paper was superfluous, inaccurate, weak. He also mentioned that these photos before and after the results can be immediate results, basically because they are lidocain. So the lidocain can affect the muscle function. If the filler doesn't contain lidocain, there is also a trauma. It's very common when we have our patients and we put a filler in any part of our face, then we ask them to smile or try to move. They feel this level of tightening. There is a trauma in the tissue. And basically, what was the concept, or what was the rationale behind these comments is that basically there should be a gold standard of quantification or evaluation of the different studies. So this was the paper who set the idea of myomodulation. Please, the next one. And what, again, and I'm going to go through exactly the same paper that I put a reference in the past. An objective, quantitative, dynamic assessment of the algorithms. And again, I'm going to use my little prop. What the authors have, they have suggested. When we have fillers, we basically inflate. Again, we inflate a good amount of our tissue. If the tissue has a movement, let's call it A, but then we overinflate, let's think about that. The movement is going to get reduced. That will be called A minus X. There is a reduction of the movement that is created by the physical limitations of the volume. The volume is going to be creating like a stop. It's going to say, okay, you are really achieving the maximum of stretching. And that was what the authors evaluated. They saw that if we restore volume, then we make movements, we have reduction of that movement, and that is associated with the amount of filler that is creating a stretching of the skin. So basically the skin is reaching a level of stretching that is the maximum. And that is not myomodulation. That is basically a reduction of the volume caused by the, reduction of the movements caused by the volume. I do believe that myomodulation might exist. Now, my conclusion to this myth is that it's not fully understood. There is no conclusive evidence, scientific evidence showing the myomodulation. There is a lot of research to be done, and what we are observing in the studies that they are already published is caused by the stretching of the skin related to the volume, not to changes on the function of the muscle. So, Dr. Turkevych, the next one.
Thank you very much. Well, now I present my point of view. In general, it's the same. Just the difference is, if we are talking about myomodulation, well, I don't believe that fillers can myomodulate the muscles totally. Why? Because myomodulation, it means plus and minus. I believe just in 50% of that. I believe that fillers can relax muscles. I don't believe that they can contract. So it's just a half portion of my modulation, what Alberto was just talking about. And I will refer to the same article, but to the other part of that article, what we should remember, and I'm not agreed, for example, with the comment of Dr. Kane, who told that it can be the result of lidocaine in the fillers. Yeah, okay, we know that Mauricio De Maio is the guy who is using just fillers of one company. It's forbidden for him not even to use, just even to think about the other company's fillers. But anyway, if we will take, for example, Alexa, yes, a filler from Hyaluronic. When I'm injecting Alexa in some very special places, especially it's in the area of Dao, this is first, I achieve myorelaxation, means less contraction of the filler. And this is the explanation in the same article, how? Because with age, we are losing fat. And we should understand that face, this is the really strong system, and nothing is working alone. Everything is connected. And when we are losing fat with the age, muscles start to contract. And when we are replacing the volume of the fat with hyaluronic acid, we can achieve some lowering of contraction, let us tell it. And this is the part of myomodulative process, yes. And here is in the summary, it's also explained. And that is why it can't be total, real myomodulation, but a lowering of the contraction that is related with the age and strongly connected with the age. And what we have no time to talk too much about this, but if you remember my previous slides about Val Lambros' work, he made the big trial, and he shows that muscle contraction in the age processes is much more important than gravity and so-called ptosis. And all this is connected between themselves, and we can inject in some places fillers to achieve the reduction of the contraction. But what you should remember that, there is no safe place on the face in total. There is no safe place, but some places are much more dangerous than the others. So you should never inject fillers in the area of glabella, yes? Not just with the idea not to have the contraction, but not to inject at all. But you can do this if we are talking about zygomaticus, if we are talking about DAO, about other elevators and depressors, but never touch there are so-called non-touch zones, and you should not to inject there, because, after today's club, I have the big experience how the people react. The most dangerous days are, this is to the audience, the most dangerous days in the practice are first 2 days after the workshop. Because the people who have heard something on the workshop try to do this. And they try to, sorry, I have to switch this off. And they are trying to put this in their practice. And those two days after the workshop, they're the most dangerous. So please, even if you will decide to achieve that relaxation effect, first, please think where you are injecting fillers, because some areas are forbidden. Well, our next topic, and now I will start. Alberto was twice the first, now I will be. It's about hyaluronic acid dermal fillers long-lasting effect, yes? Means that they can last longer than we are saying. Well, my opinion, it's shown here. This is from the Instagram, but really I like this slide very much. It's really great. And it shows a lot of things, you know, that our products last longer. Sorry guys, if we inject 14 till 20 cc, every product will last longer. The product can last longer than 12 months just in the situation, two situations. First, this is a normal quantity of the product. Because if we will inject such big quantity, we understand that for the dissolving of the filler, we need the activity of our own hyaluronidase, yes? And if we inject the big volume in one place, for sure it will dissolve slowly, more slowly than the small. For example, if we inject 1 cc in one place, or we'll inject in 10 places 0.1, the time of dissolving of that 10 injection will be much less than the time of dissolving on 1 cc injected in one place. And if we are talking about 14 cc, well, it's nothing related with evidence-based medicine. This is the first. Second, product can stay longer if it is injected in the wrong way. If we are injecting in submucosa, if we are injecting in fat pads under the eye, if we are injecting too superficially, так, там вас щось переключилося. Sorry, one moment. То все треба було повиключати. Injecting, if we are injecting it too superficially and achieving Tyndall effect, we can have, so every problematic injection can stay for long years. Напишіть, що вона перестала писати. And here is the FDA approved fillers and the time of duration, and let you see what is written. For example, for Voluma, about 24 months with touch-up treatment at 12 months. But guys, if I will take, for example, Alexa, and term of duration is approximately 12 months, maybe 1-2 months more years, and I will make touch-up treatment on 12 months, for sure I will have the same 24 months duration. So my opinion is that if the product is was injected in the right way, if the quantity was physiological, because I think that injection of 12, 14, 18, 20 cc, it's non-physiological. And by the way, you know that idea of the Maya to inject 20 cc, you know why 20? Why not 30, for example, or 40? Not because he don't want to inject 30, not because company producer don't want to inject 30, because of the very simple thing. Because in the FDA approval, it's written that not more than 20 cc can be injected per 1 year for those product line. Not more than 20 cc per 1 year. That is why this is the reason why 20, why not 25 or 30. So, well, if we injected a logical and physiological quantity, and it's very easy to understand how much, the majority of our patients are ready to pay for 3, maximum 4 syringes. 99% of my patients, they can agree for 4 syringes maximum. And even majority, they would like to have 2 syringes. And the maximum, they would like to ask me to make wall face with 1 syringe. And this is not a question, but If we are injecting the logical quantities, if we are injecting in the right way, we will have the result up to 12 months, not longer. And to achieve the longer result, we need to make the touch-up treatment. And this is regarding every filler on the market, I mean HA. I'm not talking about calcium, I'm not talking about polylactic acid, I'm not talking about synthetics, I'm talking just about HA. All the rest, it means that something was done in the wrong way. Injecting of 14 cc, it's also a wrong way. And now, Alberto, please, your opinion.
Well, in that sense, I absolutely agree with Dr. Turkevych. Here, I just want to just give some little cases. As you know, now the whole trend of injectables and medicine is about image, using ultrasound image. So I absolutely agree with Dr. Turkevych that when it's not properly injected, it can last more. And more doesn't mean better. And here I'm just going to present two cases. So one of them is a case presented in Chicago, in which Restylane was injected under eyes, clearly properly, and using different ultrasound image, but also evaluation. It was lasting more than 5 years. A filler that is basically known to last maximum 6 to 8 months. So basically 62 months after the treatment, the patient was still presenting the dermal filler. And that is something very interesting that new teams and new groups are showing using ultra high frequency ultrasound. This can have the one little clip. So basically they evaluated different products from different brands that they are promoted as short time dermal fillers, meaning 6 to 8 months, a low amount of time, and this is a grade 2 evidence, so meaning that we have to consider this evidence very important. But they were showing that even passing the date that the manufacturer was presenting, the filler were not only still there, but they were diffusing. So now that is the new concept about fillers. We have patients, as Dr. Turkevych said, that they want miracles, 1 ml, and make everything. Some brands are actually promoting that idea. Some brands are talking about using 1 ml and making everything. And we have these patients in which we use 1 ml of a strong filler, and after 1 2 months, they return and they say, I don't have anything. I don't feel anything. We used to believe in that time in the past when we didn't have the ultrasound devices showing the image that the filler was scored. But the new concept and what it's been observed is that the filler, some of them, I'm not talking about all of them, they don't get dissolved, but they diffuse. So they stand for longer time than what we think, but they are not having the volume as we're expecting. The issues that is associated with products not properly placed, amount of volume that is not the proper one, as Dr. Turkevych mentioned. So we need to take with a grain of salt the idea of how long a filler lasts. Please, can we have another slide? And just to show you very briefly, so basically one of the products that I use the most in my office is Alexa. Dr. Turkevych, please can you take one little clip? And that is something very interesting that the product is capable of. The slide is not, it's okay. So basically, that the new products, the new generation of products are making the research to show with image that the filler lasts what they promise. So the next myth that I'm going to follow up. So please, Dr. Turkevych, can you give me the next one? It's okay. It's about the next myth. Yes.
No, there is no other. Next one is our next topic.
Yes, we're going to move to the next topic because I continue.
Okay. So, well, Thank you very much for your opinions. As we see, we have the same opinions, that if it lasts longer, means something was done in the wrong way. Hopefully, if it's just quantity, then much worse is if it's like under the eye,
Wrong plane, exactly.
or something else. By the way, I want to ask our audience, guys, there are two questions. First of all, when we will finish, we want to discuss with you. So if you have any questions regarding today's topic, you can leave, Alberto, for a couple of seconds. Okay, let it be, because they switch you off. Regarding today's topic, if you have any question, if you disagree with us, or if you have your own point of view, we are waiting your questions and we will be happy to discuss with you. And the second, it's not our last debate club. And we would be happy if you will write us what topics you want to hear in the next clubs. We would be happy to prepare on those topics that are really interesting for you. So write, please, we will analyze all this and we will prepare our next club based on your requests. And questions about today's. You can disagree with us and we will be happy to discuss with you and to have some debates with auditorium. So our dermal fillers can stimulate collagen production. Well, Alberto, it's yours, so I don't know why they switch you off.
I don't know. It's okay. So, this is a topic that I think we're not going to agree.
Sorry. Guys, please change. Yes, you leave Alberto and you leave presentation, and you are switching off me.
So I think in this topic, in this part, we're not gonna agree completely. And this is also quite controversial topic. Why? Because we have so many products that they claim to do that. So we have to understand and separate ideas. A dermal filler based on hyaluronic acid or collagen stimulated products. I mean, I'm gonna say collagen stimulated products very loosely, to the products that they are synthetic based. So my answer to this is that yes, however, it depends on the composition. What we know now and what has been the most described, that calcium hydroxyapatite, a product that is synthetic, it's capable to produce collagen. It's well known that it's capable, but it's not known how. And that has been the main problem. We know that by different histological analysis, Turkevych, can I have the next just one click? So we know by histological analysis that after the application of calcium hydroxyapatite, there is a level of proliferation of fibroblasts, and those fibroblasts are producing collagen in a fibrotic way. The calcium hydroxyapatite is encapsulated, it creates a precipitation that leads to an immunological response, and that immunological response is the one that apparently will be dealing with the collagen production. The issue is that it's not fully known how. So calcium hydroxyapatite, when we think about polycaprolactone, polylactic acid, we are thinking that they produce collagen. However, as a dermal filler, let's talk about hyaluronic acid, and that is a little bit more controversial. If we are adding this highly dynamic gel that is not going to induce a strong immunogenic response, we should think that we don't have collagen production. And that is something we have known, that hyaluronic acid should be an inert. It should not have any sort of effect in the skin metabolism. That is the old concept. Now we know that it's totally different. However, some studies in vitro and in vivo, they have shown through the histological analysis that hyaluronic acid can create levels of density of collagen. So meaning that there is some level of collagen production. However, it will not be a biochemical effect in the metabolism itself. It will be a physical effect. When we have hyaluronic acid, we're going to create a level of stress that you can see in the lower schematic that is going to push the fibroblasts and different cell types in the 3D structure. And when we have this shear stress, when we have this stress, mechanical stress, creating the stretching, it's going to activate certain pathways that are still not fully known. One of them, one of the ones that is sort of like postulated is the TGF-beta pathway, that is highly inflammatory pathway, would lead to the neocollagenesis in the surrounding areas. So the hyaluronic acid will create basically a bubble of stress that will lead to the fibroblast to create more collagen. That is one of the concepts. So basically, there are, and in this field, we don't have full idea also which level the hyaluronic acid is going to make it, if it's a dermal filler with high concentrations, with very low concentration, the level of reticulation, the concentration of DDTE. So I want to separate the idea and this myth. Yes, certain dermal fillers can produce collagen if there's these synthetic dermal fillers such as calcium hydroxyapatite, polycaprolactone, and polylactic acid. We don't consider polycaprolactone and polylactic acid a filler itself, so they are collagen-stimulated compounds. And hyaluronic acid, it's been shown limited evidence, but still quite conclusive evidence that hyaluronic acid is capable to induce collagen production, but the process will be a mechanical effect, not a direct activation of the fibroblast. So the next one, and that is your term of application.
Thank you very much, Alberto. And here we are also on the same side, but I will be a little bit more aggressive in my presentation. Well-known so-called collagen stimulators, yes, hydroxyapatitis, calcium hydroxyapatitis, it's polylactic acid, and it's some people think that hyaluronic acid. We will not talk today about polylactic acid because, yes, polylactic acid, it causes the collagen production. The question is, it's also very dangerous, polylactic acid. But let us analyze what we have. Can I ask to switch on the presentation? So if we are talking about collagen stimulation, we should remember, first of all, a very simple thing. Our collagen that we have in the skin, it lasts at least 15 years. Every method of the new collagen stimulation, especially injections, they last maximum 1 year. Just PLA up to 2 years, but up to. So it's a little bit strange, yes? We are stimulating collagen and we need to re-stimulate it in 1 year maximum, and to re-stimulate and to re-stimulate. This is first. Second, all the works that were published, they were, or there was some misunderstanding in interpreting of data, or they were based on indirect data. What means indirect? If the people who were doing trials saw the signs of the possible collagen stimulation, it doesn't mean that the good collagen appeared after this. These two things, they are not connected. Let us analyze what we have about collagen stimulation by calcium hydroxyapatitis. The best and the basic work in the collagen stimulation with the calcium hydroxyapatitis was published in 2008 by Ellison Hobzapfel. And what was written there? They have proved that calcium hydroxyapatite found no evidence on new collagen formation on 1, 6, and 18 months after injection. Because what is possible It can cause the fibrosis. If we are injecting the big quantity in one place, due to the very slow biodegradation, we will have the foreign body giant cell reaction and the fibrotic capsula will appear around the calcium. Yes, this is also collagen, but we don't need such collagen, and it's not good for us. If it's injected with the small quantities, they don't found any evidence of the new collagen formation, even 18 months. But after that, some works appeared. All that works were done and published by so-called Professor Yutskovska. One was randomized split-phase histomorphological study comparing of volumetric calcium hydroxyapatitis and chronic basic acid. You know what is evidence-based medicine? If it means that question and answer are the same. Here the question was the comparing of volumetric abilities and answer was new collagen production. It's strange. Okay, there are a lot of strange things in those two works, and I will show you. The other one was improved neocollagenesis and blah, blah, blah after injection of diluted calcium. Let us analyze those works. This is the analysis of the first work. When they were learning about the calcium, I don't understand why they have such period 4 and 9 months, but we should remember that there was injected in, first of all, in the very strange place, periauricular area. I understand why they inject in periauricular area, because they were making biopsy from that area, and nobody will give them the possibility to make the biopsy from face. But this area is totally different. There is no such pads as on the face. It's really different. And one more thing, they inject 0.1 cc of calcium from one side and the same of HA. But we should remember that maximum 3 months, the volume of those two injections will be totally different. And the volume of calcium will decrease by 70% and the volume of HA will increase at least 20%. So they decide to compare two different volumes, 0.03 and 0.12 ml. And it's impossible to compare such volumes. There was the wrong place, and well, this work, it's at least strange work. But the second one about the neocollagenesis, I have analyzed that work, and what I have found, first of all, in the second article, they studied the level of CD34 as a marker of angiogenesis, but they have forgot that at least at the skin, it is not the absolute marker of angiogenesis. It's rather indirect, because in the skin, it is also present in stem cells. And when we are making some injury, some damage to the skin, like injection of calcium, it indicates the process of reparation after the damage, and not the process of the new vessels appearance. Second, what they do, that was ultrasound measurements. You know, it's very easy to write some bullshit in the paper thinking that nobody knows, but they have shown the changes in microns. But with that ultrasound scanners that they have used with the frequency of 45 megahertz, it's impossible to show the changes in microns, just in micrometers. So before publishing this, it's a good idea to open the instruction to that scanner and just to read what is the resolution. DAP skin scanner 45 megahertz can measure just in millimeters, not in micrometers. It's impossible. To measure in micrometers, it's necessary to use a skin scanner with the frequency of at least 75 or even better 90 megahertz. But they use this one, so they can't achieve such results. It's impossible, because it's impossible to achieve with such skin scanner. So how they, where they take that changes in micrometers, it also at least strange. And one more thing, it's about the statistics. They use student T criteria, but it's impossible to use such T criteria. It was necessary to use the Wilkinson criteria, and this gives the wrong results. In this regards, and what we should, but what we should understand that there is some improvement. So now we are studying what is the mechanism of action of calcium, yes, because people are injecting, a lot of doctors are injecting, they have the good result, but the mechanism, we have hypothesized what is the mechanism of action, but for sure it's not neocollagenegenesis. And I have published the work 3 months ago in the Journal of Applied Cosmetology, where all that analysis was made, where was proved that there is no evidence of neocollagenegenesis with calcium, caused by calcium at all, that all the works that try to show that it is, they were analyzed, and we show all the mistakes on that works. And we hypothesized what is the possible mechanism, but nothing regarding the new collagen production. And here are some conclusions from our article. And if we want to use dissolved calcium, we should dissolve it at least 1 to 10. So the percentage have to be not more than 3%. And using of dissolved 1 to 2, 1 to 4, even 1 to 5, it will cost the fibrosis in some places. Nothing good will be. And there will be no neocollagenesis at all. Regarding the works that Alberto also mentioned, the work of Wank, Garza, and Kant, it was interesting work. What means interesting? It was mistaked work. All their conclusions were based on mistake, on myths, but it gives for the companies the possibility to share between us some myths, that especially, yes, about Restylane, that it's miracle, we are injecting and we start to be younger. But not all people know that in 2012, there was one more article, Sundaram, Flynn, Cassuto. They published in the Journal of Drugs and Dermatology in 2000, and they have analyzed that work of Wank. And comment, small study size, evidence level 5, where HA injection actually intradermal, is fibroblastration clausiness more. And one more thing, they decide to repeat what Wang have done in vitro. And it was impossible. In vivo there was the visibility of some result, but to repeat it in vitro was impossible. So honestly, HA also doesn't cause any collagen stimulation. So finally, you can put us both on the screen. Moderator, can you put us both? Yes, great, thank you. Finally, well, I don't know, maybe Alberto have other opinion, but as for me, we have not even lack, we have total absence of any evidence of the collagen stimulation by any fillers except polylactic acid. But as told at the beginning, but it's not so easy to work with polylactic acid. Sometimes it's really dangerous. So polylactic acid, this is the good thing for example, for the big lipodystrophy.
Personally, I don't use polylactic
something
acid.
else, yes.
I don't use polylactic acid. I absolutely agree with Turkevych about the level of risk of using it, and now there are new products claiming to reduce those risks. I personally, and I think Turkevych will agree that we have to ensure the safety of our patients more than experiment with new things. I personally use only products that after 5 or 10 years there is conclusive evidence of their safeness. Even more time will be ideal. And it's very interesting the last slide, and that is also a wake-up call for all of us, including myself. Sometimes we read a very interesting paper, we see some very nice evidence, but then there's always the other side of the history. I honestly did not find the other paper that I couldn't. I don't know, maybe it was my search was not the proper one, but I couldn't find out about this reproducibility of the results regarding the hyaluronic acid was not the proper one. And that happens a lot in our field, that we base our observations in only casuistic. We see, okay, there is one effect, and then we stretch a little bit the conclusions. And the conclusions are not fully proved. There is a whole gap of knowledge missing between the observation, the outcome, and the whole knowledge of that. So I absolutely agree with that.
And well, I'm a little bit disagree. But for example, if we have patient, HIV-associated patient, yes, patient with human immunodeficiency virus.
Yeah.
We can use Sculptra. It was designed for such patients.
Exactly, that was the indication.
Such patients. And if we are talking about the volumization, because we agreed that there is no collagen stimulation, but if we are talking about volumization, starting from the time when company Hyolar have designed Alexa line, to have the good, safe, and not high priced, not too expensive HA product, it's not a problem at all. And the problem is only on those countries who has registered Xaluriderm, yes, or Hyalural, and have no Alexa. But it's their problem, and distributors have to move very quickly and to register the
Yeah, I totally agree. Yes, yes.
So our next slide, and we will. Can you put both of us together and presentation? And me too, also. Or it's impossible to put two speakers. No.
Yeah, I think it's possible.
Okay, so Alberto, you will start.
This is for me this is very fast and simple, and here I'm even more aggressive because I absolutely disagree with the idea of the use of lidocaine to reduce risk and complications. They have been I have the chance to talk with doctors all around the world, and I have been hearing some doctors or some clinics saying, I only work with fillers with lidocaine, because the fillers with lidocaine, my patients are less bruises, they have no complications, they sort of like don't feel any pain and so on. Definitely that is not true. And I'm going to show you that the old research regarding the lidocaine used in fillers have been subjective, and also there have been reports of all deposit that the lidocaine can create problems. So in the next slide, I'm going to show you just very briefly a study in which different parameters were evaluated. This is basically a systematic review of the research of the last 20 years regarding satisfaction, complications, and duration of dermal fillers. The main conclusion, with or without lidocaine, the main conclusion of this meta-analysis, or this systematic review, sorry, it was that no difference between duration, pain, hematomas, or real overall satisfaction of fillers with or without lidocaine. I see practitioners that they overabuse of the lidocaine. I see it in the region that they use nerval blocking, like a dental anesthesia, to even anesthetize more the patient, to use now a lot of trends of using mevicaine, mercaine, to improve even the pain of the patients. And here I want to be very emphatic. If you have the right technique, if you know anatomy, as Dr. Turkevych always emphasized, if you know anatomy and you really get the proper training to perform fillers, you're not going to have pain, severe pain or intolerable pain, hematomas, or issues using fillers without lidocaine. Lidocaine is not going to really make any big difference. Now, there have been reports, please, Dr. Turkevych, can you put the previous one before putting this one? So there have been reports of one previous also. There have been reports of complications related with lidocaine. This was a report also from Turkey, in which a severe hypersensitivity reaction to the lidocaine. It was concluded that was the lidocaine because then a patch test was showing that it was related to that, in which the patient got a severe edema, that it was resolved after 7 days with a proper treatment. It was antihistaminics plus oral corticosteroids. So it was a reversible, even though the photo looks very scary, it was a reversible effect. However, and the next one, please. However, it's been known that one case per 10,000 procedures present anaphylactic reactions to lidocaine as anesthetic. So we are playing, I don't want to use this name, Russian roulette, because Dr. Turkevych doesn't want to name this country, but Russian roulette in regards when we're going to face this 1 in 10,000. When it's going to be this 1 in 10,000. In my practice, I use 0 products with lidocaine. My philosophy is to use 0 lidocaine products. I use EBLA or anesthetic cream anesthesia in the proper way, and I have fought very hard to create and to optimize my techniques of injections to minimize the pain without the need of anesthesia. Is the next one, and as you can see, the results of an anaphylactic shock using hyaluronic acid with lidocaine can be quite aggressive for the patient. As practitioners, if we know the protocols how to revert these conditions, it's going to be easy and simple, but believe me, you're going to create a very unhappy patient, a patient that is going to be very scared. It's going to be very traumatic for the patient, and you increase your liability of your name and your clinic. So I encourage you to stop thinking that lidocaine or the anesthesia is giving you better results or is giving you better satisfaction rates of your patients. That is a myth. So this was the last slide, and I will ask the administrator, the admin, if he can put also Dr. Turkevych, because you can remove the slides, because I know that he has some words about it. So, Dr. Turkevych, yes?
Yeah, this one you mean?
Oh, no, because you want to...
okay.
Yeah, because you want to...
Can you put both of us? Yes, because I'm looking for the questions that appears, but I will tell my opinion about lidocaine. Look, from the business point of view, I mean, how I'm creating prices in my clinics. Let us tell it's very simple. It's plus 200% on filler, at least. And from the business point of view, it's good to use the fillers with lidocaine because they're at least 10 euros, the price is at least 10 euros higher. It means that plus 200%, I will earn 20 euros more. But from the medical, it was a joke. But from the medical point of view, I never see the reason why to use it. I will explain. Honestly, what Alberto have just told, but he don't mention one thing. Really, the anaphylaxis to lidocaine is very rare. Even more, it was anaphylaxia to the lidocaine in injection, anaphylaxia to lidocaine in the syringes, where it's not the drug lidocaine, just chemical structure. It's probably impossible, but probably. It's not for 100%. But I don't see the reason why to inject, because what it should give us. Anesthesia, sorry, but Lido will start work when I will finish. So what for? The only one thing I don't see, I'm injecting in the way that was on the last slide. So I'm injecting the majority of injection, I'm doing perpendicular to the face, because this is the best way of injecting, so-called shot technique.
Yeah.
But I don't need Lido. Even more, I have, and those who were on my workshops, they saw the technique. I know how to do that. Even the injections through skin, they don't feel the pain. When they feel something, when we are injecting, they feel the pressure. And you should remember that lidocaine just changed the possibility to feel the pain. The pressure you will feel, your patient will feel anyway. And it will start work when that feeling of pressure will finish. So I don't see the sense to pay. If we will take any company fillers, the same fillers with and without lidocaine, the difference will be at least 10-15 euros. So what for I have to pay more achieving nothing? And this is why I think this is one of the reasons why Alexa is without lidocaine. And the only one area where we need anesthesia, this is lips. But with the lips, depends on patient, I'm putting, by the way, he'll have really great, brilliant anesthetic topical. I'm putting that anesthetic, or if I have really problematic patient, I'm doing injection in infraorbitalis and injecting under the lower lip, but I'm doing injection of mepivacaine with epinephrine. And I have the guarantee that everything will be okay. I'm not using Lido. So because of what can be in the drug called lidocaine, because the majority of allergic and anaphylactic reactions were not on Lido but was on the drug. Means all that preservatives, conservatives, and using mepivacaine with, these are rare cases, but using mepivacaine with epinephrine, I have no problem at all, and I have vessel constriction, and everything is really great. But it's, well, one episode on 100 episodes. The necessity to do the injections. Right. All the rest, I'm just applying that anesthetic hyaluronic. I have great result, and 20 minutes under the occlusion and they feel nothing. They also just feel just pressure. And that's all. Well, there were the questions. I will read them, and we will answer together with Alberto. According to your observation, what amount of fillers does the effect of myomodulation depend on? Well, not myomodulation, once more, thank you for question, but relaxation. It depends which area. If we are talking, for example, about DAO, it's possible to inject 0.05 or maximum 0.1, and you will have relaxation because the muscle will feel that it is on something that muscle think it's the fat, yes? That's why it relaxed. It's not the question of big quantities. And Alberto, what's your opinion?
Yes, actually, that is a very great observation of what you did about the DAO, because when we are doing chin augmentation, we're doing a jawline, sometimes we inject with a needle. And actually, one of the techniques that I really love was from Dr. Karpinski, that I know he's online, in which he inject with needle a little bit of filler here, 0.1 per side. And in my observations is that creates it relaxes the muscle quite fast and easy. So I absolutely agree with Dr. Turkevych that depends on the area. It can be little amounts such as 0.05, 0.1, and you can have this relaxation. Now, what I have observed is a long-term relaxation of the muscle. It's not going to be something correlated with the duration of the filler. It's going to be something transient, and it's going to create a quite beautiful result, a quite beautiful change. But it's not something that I will even explain to the patient as one of the outcomes that I'm looking forward to.
Well, the next question is, are the recommendations the same when injecting fillers into the area of levators and depressors? My answer is next. Unfortunately, the contraction of depressors is much higher than contraction of levators. Because if we will have with the age the contraction of levators, nobody will come to us and tell us about so-called ptosis. We have the contraction of depressors that goes, well, a little bit, the level of depressor is the lower part of the face. And they contract, and that is why we have something that we are calling ptosis. It's not the ptosis, it's the contraction of the muscles. And when we are talking about the relaxation, we need to relax depressors. And levators, we don't need to relax them because of the only one levator that possibly needs to be relaxed, but not with fillers, it's the forehead muscle. But if we will relax it too much, we will have the proptosis. But this is not very safe, but it's useful. Sometimes we have changes, age-related changes on the forehead, and if you will use the smooth fillers, like for example, like a medium, yes, inject with big cannula, small quantities on the forehead area, you will have double effect. First of all, you will make it more smooth, yes. The structure of the forehead will looks younger, and the second, you will achieve that lowering of the contraction effect. Because we know that with botulinum toxin, we should be very careful not to inject it too low, because we will have the effect of proptosis. Also, when we are injecting forehead, for sure we need to inject also corrugators, glabella. We can inject glabella alone, but we can't inject forehead alone, never. And this is, Alberto, your opinion?
I absolutely agree, but also in the technical part, in the practical part, I love to do fillers in forehead, temples, and sometimes of soft fillers with cannula in the glabella. I know this is a dangerous area, but it's something that you can do very conservative. And the practical part, to prevent any sort of unexpected myomodulation, I call it myomodulation of the filler, my philosophy is to first attack the problem with botulinum toxin before a patient is going to have dermal fillers in forehead, temples, and in glabella. I do botulinum toxin in the whole frontalis, procerus, corrugatus, and auricularis to prevent any undesirable, unexpected effect of the dermal filler in the muscles. So I like to seal the muscles in the position that I want to then do dermal fillers. That has been at least my safer way to do it. And as Dr. Turkevych mentioned, yes, in the forehead, I always inject with cannula, small amount of product. Temples, I do the head chop technique with a stronger product. And when I do glabella, very rarely, I'm going to do cannula, very superficial, with a very soft technique, with a soft product, and be very conservative. So, yes, in that sense, I absolutely agree.
Well, one more question was about epinephrine. Epinephrine was also debated about, they said, they means we too. It is dangerous when we need to dissolve because of blockage, and we need a good vasodilatation to reduce complications. I'm totally agree, Dr. Raja, but there is one small thing. We were talking about the possibility to inject anesthetic with epinephrine, just talking about lips. Yeah. The possibility of the of embolia of the vessels, and as a result, achieving necrosis and scars in the area of lips is much lower than in any other area. Why the small embolias on the lips, why it's very easy to treat them? Because the quantity of the vessel on the lips is much higher than in the other areas. And what is the most important? If we are injecting, if we are talking about injection, for example, of the infraorbital area or mid-part or lower contour, we are afraid not such, we are afraid of possible ischemia, but the most what we are afraid is the possibility of the vision loss. If there is the embolia of arteria facialis, after that angularis, after that ophthalmica. This is the most dangerous complication. If we have just embolia, for example, embolia in the lips, I have the huge experience of treating with possibility of with different injectables, of treating and having no scars at all, even when the necrosis was. But we have the time, we can treat 1 week, 2 weeks, there is no danger of the vision loss. So you are right, but not totally, because in the lips, there is no high risk of the vision loss, because the arteria labialis, both of them, they go from arteria facialis, and the reason it will go back, well, it's very small, maybe 1 per million. And that is why, as I have told, you are right, but with the lips, it's possible. Alberto?
Yeah, in that sense, actually new products from different brands are now having special lip fillers with a little bit of vasoconstriction, because it's already well known that the chance of an embolia with vasoconstriction it's very mild. Now, again, I think that sometimes using vasoconstriction and such a strong anesthesia, nerve blocking, is something that we leave for these very complicated patients who have like a highly sensitive respond to dermal fillers. I always encourage that we can use topical anesthesia, we can optimize and refine our injectable techniques, and then we're not going to need such an amount of intervention. If you need it, the risk is minimal of having an embolia.
Well, by the way, if we start to talk about the complications, there is one more thing what we should understand. You know, big pharma, it's very aggressive business. And big companies, the major players on this market, they try to share to the doctors the idea that our product is much more safe because of the reason of the complications and others, because we are brand. And all of you have heard this. What I want to tell, first of all, the majority of complications, they appear where? In USA. Because it's the biggest market, so it means the majority of complications are on the biggest market. But we should understand that in USA, the very small quantity of fillers are registered. Just 3 or 4 companies have their registered products. And a lot of complication. It's a little bit illogic, yes? Just big brands are registered, no complication because we are brands, and majority of the complications are on the market where there are also only brands. It's a little bit illogical. One more thing, what we should understand that 99% of complications are related with doctor, with technique, with wrong injections, with lack of anatomical knowledges, with ideas to make some experiments, with do not knowing what they are doing, and just 1% is related with the product. And when we are talking about the products without lidocaine, like Alexa are, they are even less. One more thing what we should understand, for example, take into account Alexa, it's CE marked, yes? If the product is CE marked, doesn't matter, it's Alexa, it's Restylane, it's Juvederm, it's some other products. If the product has CE mark, it means it was tested on the quantity of possible complications. And that quantity should be not higher than this very small quantity, but okay, it can be. And it means that all the products are the same from the point of view of the possible complications. Even more, to be honest, I know some big companies which products cause much more complications, swelling, edema, than others. But anyway, that quantity is higher than in other products, but anyway, it is in that range of possible complication, because in the other situation, their registration will be cancelled. But let us be honest that if we are talking about the majority of CE marked fillers, I'm not talking about Chinese products, not? You know, because CE, if it is in the little bit different position, it means not CE mark, it means China export. So if they have real CE mark, it means that all the products have the same safety from the point of view of the complication related with the product. And complication related with the operator or related with the patient, they are a little bit different complication, and it have nothing connected with the product. So, well, as I understand, we have spent our 1.5 hours. I will check maybe some more questions. One moment. So, no more question. One moment. Is it possible to compare the effect of the collagen stimulation with apparatus procedures? Honestly, I don't understand the question means to compare, but I have told there is no collagen stimulation from injectables at all. Even more, there is no physiological collagen stimulation from EBD devices. It doesn't mean that we should not use them. I have in my clinic, I have a lot of EBDs, but I'm not stimulating collagen. I'm doing totally different things. There are really very good articles were published during last time, and the ideas about epidermal-dermal junction, about dermal-subdermal junction, about usage of RF, about usage of ultrasound to influence on the junctions and to restore them, and after the restoring, the quantity of HA start to be normal, the quantity of the collagen due to the influence on the caveolin start to be normal, I mean as it was 20-30 years ago when we were young. And everything is restoring, and nobody is fighting for the collagen stimulation, because it's not the biggest problem. There are much higher problems, much bigger problems in that happens with the skin. And you know that idea of the collagen stimulation. Okay, guys, if we will cut skin with knife, we will also have the collagen stimulation. The result will be scar. You need to have intradermal scars? I don't think so. We need not to stimulate the collagen. We need to restore the skin. And one of the way of the restoring of the skin is, for example, injecting of celery derm with different concentration of HA. It depends on the phase type, yes, but with the same concentration of the succinic acid. And this is the way of restoring, of the physiological restoring of the skin. So please stop playing that games with collagen stimulation, with facelifting, with other, I think. Try to stand on the side of good, yes, not on the side of evil. Side of something good is the evidence-based medicine. And if you will be on the side of good forces, on the side of evidence-based medicine, you will stop to do a lot of things that have no sense with lack of evidence, and everything will be okay in your life, and you will really start to achieve good results. You will have happy patients, and they will be ready to pay you as much money as they have to pay. Alberto?
Well, that was a very interesting point, because you took different concepts, and that was very good. So regarding the question, there are no conclusive or serious studies comparing about the collagen production, one device versus injectable. However, what is very important, as Dr. Turkevych mentioned, we overpush the idea of collagen, but the aging process is a very complex metabolic change that involves multiple pathways, and one of them is the collagen production. But we overpush the idea of collagen. We think that more is better. Just to give you an example, there are pathological conditions associated with hyperproduction of collagen. Kidney fibrosis is basically a process in which we have hyperactivity of the TGF-beta pathway, and then we have excess of collagen that is creating a fibrosis in the tissue of the kidney. So more doesn't mean better. It means the amount that is the right one. So when we think about the skin, of course we want to stimulate collagen, but that shouldn't be our main focus. Our focus should be to establish a proper balance in the metabolism, to have also elastin, to reduce oxidative stress, to reduce inflammation, to have the proper vascularization, to have the levels of oxygen appropriate. So in specific to the question, energy-based devices, I also, as Dr. Turkevych mentioned, I use them also a lot. I like them, but for me, they are a complement of all these. A complement in the concept of stimulating complete restoration of the metabolism of the skin. So let's not always focus as the collagen as this key molecule that is going to rejuvenate everything. That is not the idea. Personally, when I talk about collagen-stimulated injectables, that after Dr. Turkevych's explanation, there are not so many. Polylactic acid will be the only one, and it's the most dangerous one. Versus energy-based devices, I'm more in favor of energy-based devices. I find that energy-based devices have less potential side effects, but at the same time can stimulate a more physiological collagen production than pushing it through a synthetic compound that can make other damage, like the polylactic acid and the complications. However, again, as the question was asking, there are no comparisons because there are no proper studies to say, okay, this one stimulates more collagen than this one. And again, going back to Dr. Turkevych mentioned, we don't have to think that more is better. So even if we have a comparative analysis and we say injectables produce more collagen, that shouldn't be an idea that we only have to change to injectable and stop using devices, because more doesn't mean better.
Yes, you're totally right. And even more, I don't understand why people are trying to stimulate collagen, because the main problem is not lack of collagen. The main problem are totally different processes, and the main problem with losing of HA, the main problem is inflammation, the main problem are free radicals, and collagen loss, it's not the main problem. If we will normalize all the environment, the collagen production will start to be normal by itself. If we will not normalize the environment in the skin, I mean,
Yeah.
There is no sense to, and as I have told, even that works with lack of evidence, even they show that we should to re-stimulate and to re-stimulate every year. So, you know, if we will stimulate such, well, so often, there is the risk that we will just, we will lose that collagen and then you will not stimulate at all.
Absolutely, and that is also what Dr. Turkevych is saying, that there are multiple effects, but sorry, multiple causes of the aging process. But also we have to think that we have structural problems, and I'm going back to what Dr. Turkevych said about distributors only having cellular derma, not having Alexa. We have to think about bone reabsorption, lack of volume, fat pads volume, lack of elevation through the weakening of ligaments. So we have to think that the aging process is also more complex than what we think, and we need to attack it in different layers. And if we only focus about collagen, we are in the wrong pathway. We're not going to have successful results, and we're not going to have happy patients at the end.
And one more thing, what I want to tell before we will tell you goodbye, it's to remember that the true Yas is here. If you are not young here, doesn't matter what you will do and how much collagen you will stimulate, the result will be zero.
Absolutely. That's why, for example, I get asked a lot by my patients if oral supplementation of collagen has any effects in the skin. I tell them immediately that the evidence have shown, the medical evidence and scientific evidence has shown that it has zero effect in the skin. So basically, having oral supplementation of collagen is not going to be a real anti-aging treatment. And there are a lot of pharmaceutical companies pushing for the supplements of collagen. And unfortunately, I tell my patients, I'm sorry, but it's not going to have any real effect.
Yes. So, thank you to all the participants. Thanks to my, I can't tell opponent, my vis-a-vis. Thanks to my vis-a-vis, Dr. Alberto. We were happy to make that first, and I hope it's not the last, for sure not least, but I hope also not the last, our club. And we are waiting for next meetings. And if you want to hear some topics, if you want us to discuss about something, just ask and we will do this. And thanks for being today with us, because what I see is that hundreds of people are here. They are with us. Not all of them have all the time right connection, good sound, or good picture. But don't be afraid. All the webinar, if it was recorded, and you can ask your local representative, and they will tell you where are the recording, where it's possible to see, to look once more, to analyze, and maybe have some questions for the next affairs.
Yes, okay. Thank you so much, everyone, for assisting. Thank you, Dr. Turkevych, for your time. We apologize for any technical problems. However, it's going to be recorded, as Dr. Turkevych said. This was the first, so it was also a little bit of a pilot for us to establish, and we were not expecting the number of doctors, so maybe the connection was not the best, but we appreciate and always open to hear from you, questions, recommendations, feedback. So thank you so much.
Okay, so thanks, and thank you to all the technical team.
Yes, thank you for helping us. Thank you.
Bye-bye.